Good afternoon, everyone, and welcome to our webinar. Today, we're going to be talking about anxiety disorders in children, how to spot them, how to seek treatment, and how you can help your child cope with anxiety through the COVID-19 pandemic. Speaking for us today, we have Dr. Stasi, Dr. Issacs, and Dr. Kane, who are three of our esteemed neuropsychologists here at North Shore Pediatric Therapy. And after the webinar, there will be a Q&A session, so please stick around for that and keep any questions you might have in mind. Without further ado, I'll hand this off to Dr. Stasi.
Hello, so we're going to be talking about anxiety disorders in children and what parents need to know. Childhood anxiety. Anxiety disorders are recognized as one of the most common class of psychiatric disorders affecting children and adolescents. We know that many children have the disorder, but many children don't get support. Studies indicate that less than 20% of children that require mental health services actually receive the necessary intervention they'll need. And we'll talk a little bit about historical context. There is a group of psychologists, Watson and Rayner, in 1920. And what they're talking about is that anxiety can be a learned behavior. And that's important in that a lot of times we know there might be a stressful event or someone might have a genetic predisposition to anxiety, but we can also learn anxiety. So what they did is they had an experiment with a little boy named Albert, and they showed him a white bunny. And every time he would come up and touch the bunny, they would crash a cymbal behind him and cause him to start crying. And what happened eventually is he started getting extremely fearful. Anytime the bunny came out of the cage, he'd start crying. But then it also transferred to any white furry objects such as Santa Claus's beard. So the anxiety was initially for the bunny, he learned it there, but then it also transferred to any white furry object.
So childhood anxiety disorders, according to the DSM, which is our manual for diagnostic disorders, there are several different kinds of anxiety disorders. All disorders share anxiety as a predominant feature, but what distinguishes the various disorders is the focus of the anxiety.
The first one that we'll be talking about is separation anxiety disorder, which is a type of anxiety. About 1 in 25 children experience separation anxiety, and it's characterized by excessive anxiety and fear concerning separation from home or from those to whom the child is attached, often parents. It's really common for children to experience separation anxiety from approximately 7 months to 6 years. So by definition, the anxiety must be inappropriate for the age and developmental level of the child. Again, the primary fear is losing or becoming separated from their major attachment figure.
And the avoidance behaviors that the child exhibits are thought to be along a continuum from mild to severe. And that's going to kind of guide treatment of how much intervention do we need to put forth, and do we really need to intervene for the child based on the continuum level. So the mild, this is where the child wants the parent to be available by phone during school hours or to be accessible when he or she is attending outings, sleepover, going to a friend's house, that they have a cell phone can reach the parent. So mild is probably not as extreme that we probably don't need to intervene too much for. Moderate, this is where it impacts the child. We're going to start having refusal to attend sleepovers or outings, requiring separation from parents for several hours. And then severe is when we definitely need intervention. That's going to be refuse to attend school, sleep in their own rooms. And this is the child that might be clingy and shadow the parent constantly.
So typical behavior symptoms often occur on a fairly regular basis on weekdays, but not on weekends. And some of the reasons for that might be, on weekends, they get to stay home more, they get to stay with their the figure that they're attached to more. They don't have to follow sort of like a predetermined schedule. Maybe it's a little less rigid in the expectations. And there's exposure to fewer people often on weekends than on weekdays. So like maybe they don't have to go to classes that they have after school or activities or things like that. Very young lying and clinging behaviors when parents leave or pick up children, despondent or avoidant behaviors in group activities, anticipatory worries before events. Oftentimes kids will ask like reassurance questions like who's going to be there, how many people will be there, Do you know what time to pick me up? Do you know what door to pick me up at? Fearful responses to changes in routines. Young children, ages 5 to 8, report often fears of harm befalling attachment figures, and there's often school refusal.
Some symptoms that are related that we often see in selective mutism are somatic complaints, so headaches, stomach aches. Often children might drop out of activities like clubs or sports, and friendships may wane. Although in general, children with separation anxiety disorder are usually pretty socially skilled and well liked by their peers, so much so that sometimes we can use their peers to facilitate communication in the school environment.
So selective mutism is often found in separation anxiety. And this is where the child has the failure to speak in specific social situations in which there's an expectation for him or her to speak. School, etc., outings, Boy Scouts, but they will speak in the home or presence of immediate family. It's often associated with excessive shyness, fear of social embarrassment, social isolation and withdrawal, clinginess, negativism, temper tantrums, and sometimes oppositional behaviors. Development of selective mutism is usually when the child is young, before age 5, but it often might not come to clinical attention until the child's in school, when there's really more set expectations for him or her to engage in communication. And many children actually outgrow the disorder without any form of intervention.
Specific phobias are a marked fear of or anxiety about a specific object or situation. So the phobic object almost always provokes immediate fear. The object is actively avoided. It's common to have multiple specific phobias.
Specific phobias develop sometimes following a traumatic event, or even observing others who have experienced a traumatic event. Sometimes they come about because of an unexpected panic attack in a feared situation, or through informational transmission, so through the media. Often it's hard to recall a specific event. So we might not know what the catalyst is, but still there is a phobic response.
Social anxiety. This is where the child will have a marked fear or anxiety about one or more social situations in which the child is exposed to possible scrutiny by others. So anytime there might be a performance situation, playing a sport, performing in instrument, or even reading out loud in class. The child fears that he or she will act in a way that will be negatively evaluated. So the biggest thing about social anxiety is the fear of being judged by others in a negative format. And social situations almost always provoke fear. Usually social anxiety is around 13 years of age, and it may follow a stressful and humiliating experience. So the child that may fall down in a sporting event or mess up in a recital, they then develop this fear for future performances.
Such recurrent, unexpected surge of intense fear or intense discomfort that reaches a peak within minutes. Oftentimes, it's not even just the panic attack that can cause a panic disorder, but once you've had a panic attack, it can be the fear of having a panic. The fear of actually having one causes you fear. A panic attack include heart palpitations, sweating, trembling or shaking, sensations of shortness of breath, feelings of choking, chest pain or discomfort, nausea or abdominal distress.
Some other symptoms are feeling dizzy, unsteady or faint, having chills or heat sensations, paresthesias, which is numbness or tingling in the body, derealization, which is a feeling like your surrounding isn't real, fear of losing control, and fear of dying. Often panic attacks are described as if someone feels like they're going to die in that moment, which is what makes them so scary.
Panic attacks usually happen in young adults. It's very rare to happen in childhood, but it can happen.
Agoraphobia. So literally it translates to fear of the marketplace. So it is a marked fear or anxiety about two or more of the following. So using public transportation, being in open spaces like parking lots, markets, being in enclosed spaces like theaters, being outside of the home.
So the development of agoraphobia, it's rare in children, and the age of onset is usually 17 years or older, and complete remission is rare.
Generalized anxiety disorder. This is excessive anxiety and worrying occurring more days than not for at least 6 months. And this is where the child or individual is unable to control their anxiety.
Symptoms of generalized anxiety disorder, and usually there's only one symptom required for children. So restlessness or fatigue, feeling keyed up. Restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbances.
And Dr. Kane's having some technical difficulties.
Oftentimes,
So I know Dr. Kane's having some technical difficulties, but it was basically the symptoms are restlessness, being fatigued, difficulty concentrating, and some sleep disturbances.
Now, how generalized anxiety disorder develops, a lot of individuals report feeling anxious and nervous all of their lives. And children and adolescents tend to worry more about school and sporting performances. So we'll notice that it starts in those school-related things before it becomes more generalized to anything and everything.
And then long-term consequences of anxiety disorders, and these are going to be grouped together, that any of the disorders that we talked about. You might have repeated school absences, impaired relations with peers. And again, these children often have social skills, but because of the anxiety, the fear of engaging, the fear of going to a sleepover, it's going to impact the child's social success. Low self-esteem. There's a high comorbidity of alcohol and drug use, and that's usually going to be self-medicate for children and adolescents and young adults who do not get treatment. There were problems adjusting to the work situations, and then could lead to future anxiety disorders in adulthood. And one of the questions is anxiety always bad? And it's not. Anxiety often serves us to warn us of novel or threatening situations. It's normal for children who encounter new situations, separation parents, first day of school in the dark. So you want a fair, healthy dose of anxiety, but you don't want it to the point that it's overwhelming and the individual is shutting down.
Okay. 2 large studies, 21% of children sampled reported symptoms consistent with diagnoses of an anxiety disorder. Approximately 13 of every 100 children ages 9 to 17 experience some type of anxiety disorder, with girls affected more often than boys.
There was another study that looked at the general course of anxiety disorders, and what they found was that 82% of children recovered from initial anxiety after 4 years, 68% recovered after their first year, and 8% relapsed. There's evidence of relapse of anxiety after remission.
And what we know, there are often coexisting disorders with anxiety disorders. It's believed that upwards of 50% of children with an anxiety disorder have a secondary psychological concern, such as a tic disorder, major depression, adjustment disorder, obstacle defiant disorder, specific learning disabilities, ADHD, or an other anxiety disorder.
Some research indicates that basic temperament has a role in childhood anxiety, with some children being very shy and restrained in unfamiliar situations. That could possibly be a risk factor, possibly not.
There are some genetic factors that are involved in anxiety disorders. Children are more likely to have an anxiety disorder if their parent has one as well. And then we're also talking about whether it's biology or environment. And what we know is on the next slide. that when someone with a more relaxed nature is in a good environment, the result is a happy, laid back individual. When you have a relaxed nature in a negative environment, they may survive and recover well from that environment without any significant anxiety. However, when you take a more anxious person in a positive environment, they would benefit from upbringing and cope with anxiety in adulthood as well. When we combine a naturally anxious person in a poor environment, then they could have ongoing anxiety problems as an adult.
Neuroanatomy, if you're, we're not going to spend a lot of time on this, but what we know about is there's certain neurological structures, such as the amygdala, which have a lot to do with our emotional responses and connected with our frontal lobe response as well. And the frontal lobes are critical for the perception of good and bad of how we will respond. So now we can talk a little bit about the treatment of anxiety.
Anxiety in the time of COVID. So this is, of course, a hot button issue right now. We get tons of questions about this. We see an uptick in kids that may have been a little bit anxious before, and within like the last year or so, it's really ramped up quite a bit. We know that there's been an increase in rates of anxiety disorders. We know that kids may be anxious in general, but there are also situational factors that contribute to anxiety. E-learning hasn't been a ton of fun for most kids. Being cut off from their social circles has been pretty tough. Fear of the unknown, what's going to happen next, that's really exacerbated anxiety in a lot of kids. The question, though, becomes when to treat it. When does it become a clinical issue? And really the rule of thumb is, if it's interfering with their ability to function, if they can't sleep, if it's changing how they're eating, if they're really starting to withdraw from any sort of interaction, at that point, then yeah, that's something that we would want to address.
So some of the things that are available to help reduce anxiety are cognitive behavioral therapy, relaxation techniques, biofeedback, which is a non-invasive treatment technique that helps patients get feedback from how their body or brain is functioning, and then using that information to improve their body or brain function. So they are attached to like different sensors that capture and measure heart rate and blood pressure and brain activity. And then when the client perceives that information, they can do different things to change their heart rate, their breathing, and their blood pressure. Family therapy is also helpful in treating anxiety disorders, parent training, and medication.
With family therapy, the way we look at it as diagnosticians is that when we're sending a kid to therapy, the child needs more support and needs support for the parents to learn the strategies that the child's learning in therapy. So part of what we want to work on is teasing out any family issues that can contribute to the child's anxiety. Is there a sense of perfectionism? Does the child expect that they have to get all A's on their spelling test this week? It creates a sense of teamwork and reduces the feeling that it's the child's problem. You're not just sending the kid to therapy, but the whole family is going together to learn strategies to help out. And it can also reveal if something that parents are doing contributes to anxiety, like separation anxiety is a big one. Oftentimes, what happens is the parental response to how the child is acting may increase the likelihood of future incidents of clinginess or not going to an event.
So teachers can help out by being aware of any changes in their students, or if they feel like their kids in their class are being withdrawn or not participating. One of the things that teachers can do is engage with the family, talk with the family, note any behaviors that they notice are unusual, especially if this is a teacher that's, familiar with the child from the school setting even before COVID. It may be a new teacher that they have this year, but maybe they can consult with teachers that the child has had before when it was in-person learning. Even kids that are doing in-person learning, they may be exhibiting anxiety in the classroom because the world is a different place. And so some of the things that can be done are making adaptations. So, kids may be feeling overwhelmed. Maybe they need a plan for transition that incorporates different routines, or having check-ins, between the parents and the teachers to see what's working and what isn't, what sorts of things are overwhelming for kids. Really what it comes down to is communication between the school and the family. Everyone's kind of dealing with, I hate the phrase new normal, but it is a bit of a new normal. And so learning ways to adapt.
Ways that we can detect anxiety in or about school really is best captured by avoidance behaviors, whether a child might be avoiding group work or presentations. They might be avoiding the classroom altogether by spending a lot of time in the bathroom or at the nurse's office. They might be trying to avoid going to school, period, by having physical and somatic complaints of like headaches and stomach aches in the morning before they have to leave.
So strategies for managing anxiety in school, teaching deep breathing exercises, slow, deep breaths through the nose, out through the mouth, positive self-talk, saying positive phrases, I can do this, I am smart, I know this. And a lot of times we'll have the kid that makes a lot of self-disparaging comments, right? I'm dumb, I can't handle this. So we really want to try to get that mindset changed. Special objects as a reminder of home. If a child being away from home, might be a picture of a parent's in the backpack or anything like that. Plan check-ins with the school social worker or never trusted adult staff in school. So you may not have necessary ongoing weekly social work, but have a point person in the school to check on the child, check in with the teacher about how things have been going.
All right, well, thank you so much, Dr. Stasi, Dr. Issacs, Dr. Kane. We're gonna now move on to our Q&A section. So if you guys have any questions about the presentation, go ahead and submit those questions using the question and answer tool. It should be somewhere on your Zoom screen. And in the meantime, I'm going to go ahead and pull up some of our survey questions. All right, so a lot of people who filled out the pre-webinar survey were really interested in what is the difference between regular nervousness and clinical anxiety. So when does just regular nervous behavior become something that can be diagnosed?
Sure, and I think the answer to that is that when it starts having an impact on the child's life. So again, anxiety is not necessarily a bad thing. If it keeps the kid driven, they're getting their work done, they're seeking peers out for socialization, we're okay with that. But if it gets to the point that the child is overwhelmed, can't sleep at night, avoids engaging with peers, can't seem to finish their work because they just think about it too much or erase everything, then you got to get some support.
Okay, it looks like another common question was, what's the difference between a child just being quote unquote shy and having social anxiety?
It's to the extent that the anxiety impacts, right? So there are many children who are shy that want to prefer not participate in class, not want to give a class presentation. But the social anxiety is the child that will get extremely upset about it, maybe go to the nurse's office before the class, complain about stomach aches, headaches, try to avoid the task at hand. So a lot of times with social anxiety, we're seeing a lot of avoidance behaviors of the feared social event. If the child is just shy, maybe a little scared, but they still go through with the event, then we're okay.
Okay, and we just got a good question. What are some strategies to address the child's lack of social emotional connectivity with peers or even their teachers, etc., during e-learning?
So, can you read that one again, please?
Sorry, sure. What are some strategies to address the child's lack of social or emotional connectivity with peers or even teachers during e-learning?
Well, that's difficult, right? I mean, if all the e-learning right now is done through Zoom, there's limited face-to-face context with peers, with teachers. One recommendation would be to try set up Zoom play dates with children, right? To see if they can even engage talking about Minecraft together or play Roblox together online somehow. talking to teachers, having like maybe a set time once a week that the child can reach out to the teacher for follow-up questions that he or she has.
And the last one I'll ask, there was quite a few people that touched on ADHD and anxiety coexisting together. Is there a very distinct difference between the two, or do they usually just coexist?
There's a distinct difference between the two disorders, but they do often coexist.
Okay, we just had a new question roll in. Does anxiety lead to misbehavior, or is this likely anxiety combined with something else?
It could be both. So sometimes when we are really anxious, it's hard to regulate our emotions. And we know that children sometimes will show us how they're feeling instead of telling us. But it can also be indicative of something else going on. Sometimes when we see like anxiety in combination with the impulsivity inherent in ADHD, we do see a lot of difficulties with behavior. So that's an example.
Thank you so much. That will wrap up our question and answer portion of the webinar. You can follow us on kidsblossom.com if you want to get this webinar. Also, I had a question if this was going to be recorded. This is going to be recorded, and we will send a copy of this to your email. So no worries. I saw a few of you joined a little late. So if you want to review the beginning portion of this video, it will be in your email later on. You can email any questions that you have to askneuro@kidsblossom.com, or you can call us on the number provided on your screen. We do 15-minute free consults if you're interested. And stay tuned for our next webinar. If you don't have a pen and paper handy, don't worry, we'll also be emailing you all this information as well. Thank you so much to whoever attended this webinar. Stay tuned for the next one. Thank you so much. Have a great day.